Okay. Good morning, everyone. My name is Jake Ballon, and I'm happy to be presenting today along with Doug Noordsy.
Good morning, everyone. Doug Noordsy here.
And we are psychiatrists at Stanford and direct the Inspire Clinic at Stanford, which is our clinic that focuses on people experiencing psychosis. And so we're going to talk about treatments and things relating to how we think of comprehensive treatment for the whole person. So there we are there. This, just as a way of saying, this is a webinar that's part of a series of webinars through the National TA Network. So I hope that you will all consider coming and listening to and participating in many of the other webinars that will be coming along in this series. Also, to be aware, there will be a survey sent out at the end of this that we hope you will complete as well. By way of disclosures, I have received some research funding from Otsuka and from Alkermes and do a little bit of consulting for Pear Therapeutics and for Alkermes.
And Doug Noordsy here. I have research funding from Janssen for an early psychosis study and consult for Pear Therapeutics as well.
Okay. So by way of an outline, we want to talk a little bit in general about metabolic dysregulation. That's a thing that as we go through it, I'm sure will seem familiar for all who are taking care of people who experience psychosis. We want to talk a little bit about specifically what we know about those in the early stages of psychosis, in particular, even those before they've received any medication and what some of the risks are associated with, or the things that have been associated with psychosis in general. Then the impact of medication, some guidelines for testing and monitoring, and lastly, some treatment strategies that we leave on with some things to do for everybody. So metabolic syndrome is a term that you may be familiar with. It's evolved over time, and in fact, I imagine that now that there's new blood pressure standards that just were announced recently that may change again. But for the time being, when we're talking about metabolic syndrome, this is several symptoms or signs that are put together that lead to increased risk for cardiovascular disease in particular. It's heart disease and stroke. And these are modifiable risk factors that we want to make sure that we are paying attention to in folks so that we can try our best to help get them back on the right side of the line when at all possible. In particular, we look at abdominal obesity, and so you see the waist circumference of greater than 40 in men, greater than 35 in women inches, that in particular focusing on fat that's stored in the abdomen area. That seems to be the most associated with insulin resistance, diabetes, and therefore downstream cardiovascular disease. Along with that, we see that elevations in triglycerides over 150 milligrams per deciliter is on there. HDL, or the good cholesterol, if you will, the low amounts of that leads to increased risk. And then blood pressure, systolic blood pressure greater than 130, or diastolic greater than 85 millimeters of mercury. That would be hypertension or borderline hypertension. So that also is a factor. And then an abnormal fasting glucose. And so fasting glucose above 100 milligrams per deciliter puts a person into pre-diabetes range, and therefore is something that we would want to address.
Doug Noordsy here. I'll just jump in for a moment. I'll be talking about physical exercise towards the later part of the presentation. And just to point out that the HDL cholesterol, or the good cholesterol, is highly correlated with physical exercise. In fact, if you are asking your clients regularly about their exercise regime, you'll find that when you test their cholesterols, usually the people that are getting regular exercise are going to be meeting the higher level HDLs, meeting the better health criteria, and that people who are low typically are more sedentary. So it's a strong correlate that you can show to your patients and help them think about a specific way to manage it. Well, again, we'll talk about that more later in the hour.
Yep, important to remember that modifiable risk factors means there's things that we can do to try to help get them back on the right side of the line. So why is this important in particular in psychosis or in schizophrenia? That we know that there are a number of, well, in particular, we know that there's a shortened lifespan in schizophrenia. People who have a psychotic disorder have anywhere from a 10 to a 25-year shortened lifespan, depending on the study that's evaluated this. And it can be for a number of different factors, although I would argue that they're all relatively interrelated factors. So we think about schizophrenia having, or people with schizophrenia having an increased likelihood of smoking, more sedentary lifestyle. There's a lot of reasons why that might be. Obviously, both of those are going to bode poorly for overall metabolic health. And then as a result of that, the number one cause of death in people with schizophrenia is cardiovascular disease, and diabetes goes along with that. Diabetes is a potent risk factor for cardiovascular disease. If you're thinking about how potent of a risk factor diabetes is for heart disease, it is considered the same as smoking when thinking about overall risk factors. So diabetes is a tremendous risk factor, and I think we've all probably seen patients who have developed diabetes, and we'll talk a little bit about the risks of that as well, even before medication. And then we add on the risk for medication, and we've all seen what has happened when you give people certain medications, and we'll talk a little bit about which ones maybe have a greater risk than others, but all antipsychotic medications carry some metabolic risk. And then, of course, lifespan is shortened by suicide as well, which may or may not necessarily interrelate with all these others, but I imagine that in many cases it can. So this is something that I want to make sure we think about as far as, schizophrenia and psychosis is a brain disorder, but actually it's a whole body disorder. And these are all the areas where, not necessarily all the areas, but many of the areas throughout the body where metabolic disease and metabolic processes take place. And one of the points that I'd like to leave from the get-go is to think that when you take a medication, it goes throughout the whole body, right? And so it may seem like that medicine is going to treat a neurochemical dysfunction, something in the brain, but actually it goes beyond that, and it gets into the pancreas, which we'll talk about more specifically, but it gets into all these other areas. And so, but in the brain, and the brain and the body, first of all, the rest of the body, feed back on each other. So they're in a constant state of communication, and as one part of the body gets more active, other parts balance out. So in the brain, we have areas like the hypothalamus that regulate appetite and satiety, but that also controls what the amount of glucose that is produced from the liver. And the liver is a major area that produces blood sugar. And so then the liver, you see going down, is producing blood sugar, but also is causing fat to break down. The pancreas, which is the real hub of all of this, where insulin, which helps lower blood sugar and is released in response to blood sugar, is released, but also glucagon, which is what you release when you have a low blood sugar and you need to produce more from the liver and elsewhere. And so the pancreas is your real regulator. But then there's also all of this happening in the gut, and the gut is a tremendously rich part of the body as far as not just regulation metabolically, but there are serotonin receptors, and serotonin is produced in there, and a number of other neurotransmitters that, again, feed back. And interesting that we think of these as neurotransmitters, which connotes that there's activity in the brain, and yet they're produced and are active throughout the body, in particular in the gut and the pancreas. Again, muscle is another place that helps regulate glucose uptake, as does fat, in sort of opposite ways, which again is one of the reasons why we'll talk in large part about the effect of exercise, and how exercise can have benefits even when weight loss isn't necessarily the goal or is not necessarily realized. So backing up a little, the core symptoms of schizophrenia would, if you look in the DSM, are things like delusions, hallucinations, which I think that's the stuff that we tend to think about the most. But when we start thinking about what are the areas where we want to intervene as far as long-term prognosis, that's where we get into areas like negative symptoms and lack of motivation and difficulty with relating with other people, and the cognitive symptoms, in particular, difficulty with executive functioning and verbal learning. But what I would like to argue is that we think about actually that there's a hidden fifth core symptom, and that would be that there's actually metabolic symptoms are a feature and a real core aspect of schizophrenia. I would actually argue, and I'll show some data in just a minute, that there actually may be, I think, some people who don't quite reach the threshold for delusions and hallucinations enough to be identified as experiencing psychosis, but are still at greater risk because they share some genetic features that make them at a greater risk for having this adverse metabolic state. But we don't realize that they don't get the antipsychotics because they don't actually have psychosis, but there's that shared genetic material, shared genetic risk, and we'll show some data supporting some of that also a little bit later. So this is a slide I like to show because it's very old, and it comes from a time before there were any antipsychotics. And you'll see that there are four glucose curves here. So there's sort of four collections. If you can read it, there's all the way on the left, it says that's people who are not identified with psychosis, so healthy controls. And the next three curves are all people who have some version of psychosis. Now, at this stage in history, definitions were a little different than they are now, and the presentations were a little bit different, but nonetheless, these are people who were noted to have psychosis. And you can see that the first curve, this is a glucose tolerance test. So in a glucose tolerance test, the person drinks a measured amount of glucose, in this case 100 grams. Nowadays, at least when we do it, we give them a bottle of what we call glucola, and you just drink it down the hatch as fast as possible. We measure blood sugar before you take it. We measure blood sugar right after you drink it, and then at sequential time points, usually every 30 minutes for 2 hours. And that would be a 2-hour glucose tolerance test. Now, what typically happens is what you see in the first curve, which is as soon as you drink this glucose drink, your blood sugar skyrockets. But that's because your pancreas is getting sense that, oh, there's an influx of sugar. The pancreas wants to regulate and keep things on balance, and so releases insulin, and that insulin comes and metabolizes the blood sugar and gets it all stored away as glycogen. And but the release of insulin is sufficient enough that actually you can see it goes a little bit below the line afterwards, and then very quickly, and by 2 hours, is back to where you were when you started. But if your insulin doesn't work very well because you have insulin resistance, for example, which is what we're going to talk about as a major risk factor for the development of diabetes, you get what you see in the next two curves, which is you take the glucose and your body can't fight that off fast enough. And so rather than very quickly coming back down and even going below the line, you can see that there's a large area under the curve, as we say, but it goes up and stays up for the duration of those 2 hours. And maybe it's just the very, very end kind of comes below the line. But there's a lot more effect of that. That glucose is now circulating throughout the body a lot longer. And if this was the kind of thing that was happening on a regular basis, you start to have, imagining how you could have the problems of increased blood sugar that we know and the effects of diabetes. The fourth one is, again, is chronic psychosis as well. It's a little bit more similar to the first curve, but in as far as the shape is concerned, but even still is the area under the curve, especially in that beginning part, is much greater. And so even with treatment, which in those days was a variety of things, none of which were antipsychotics, it was still dysregulated for the patients there. So moving forward a little bit into, this is a study that came out from Ireland in the early 2000s. It looked at about 40 patients, about 40 controlled subjects, about 40 first-degree relatives. And this is where I start to believe that, in fact, there is some shared phenotype or shared features between first-degree relatives who don't have psychosis and the identified patients. And you can see that in red are the non-significant areas. So the things that didn't come significant was that fasting glucose between the patients and the controlled subjects and the first-degree relatives were considered, statistically similar, as was the hemoglobin A1C. So hemoglobin A1C is the measure of how an average measure of blood sugar over approximately 3 months. And so these were all are within the normal range. A hemoglobin above 6, hemoglobin A1C above 6 start to indicate risk for insulin resistance and diabetes. And so these were within the normal range. But if we start looking and we can see signs though that the patients and the first-degree relatives are kind of on the wrong track metabolically compared to the control subject. So fasting glucose and hemoglobin A1C are kind of the last things we would expect to be abnormal, because the body has such a great capacity for compensating for dysfunction. But we can see that when you do the glucose tolerance test, that the patients and the relatives both are at 6, whereas the control subjects are 4.5, which is a notable difference and statistically and clinically significant, meaning that they are needing to pump out, they're not clearing that glucose as fast, right? And we can see also in moving down towards the bottom, where there's what's called HOMA-IR, which is a measure of insulin resistance that helps recognize sort of overall the ratio between glucose and insulin. That's also abnormal, and that's driven in large part by the profound difference that we see in the 2-hour insulin and the fasting insulin. So these folks, the patients and their relatives, are both at baseline pumping out more insulin, which means just to stay, without even a glucose challenge, their insulin is not working as efficiently as the control subjects. They need to make more insulin to stay balanced. But then when you give the big slug of glucola, well, now you can see that the amount of insulin they need to produce in order to clear out that additional blood sugar is nearly threefold what is needed from the control subject. So their insulin is far less efficient. Inefficient insulin is also called resistant insulin, and so that's the state of insulin resistance we talk about that is the precursor to diabetes. So they haven't met diabetes yet in this sample because their fasting glucose and their A1C are still normal. But the more insulin that you produce, at some point the pancreas can't keep up with that. And when the pancreas starts to burn out, that's when you convert from having insulin resistance and these high amounts of insulin to ultimately into diabetes. Now the last one on here is also not significant, and that is leptin. Leptin is a hormone that is associated with fat, and so again, these are people who have not had any medication yet, and we know that prior to medication, people with psychosis are actually not at a greater risk of obesity compared to the general population, and so that's borne out here in these numbers as well. And I mentioned in the beginning that abdominal obesity is associated with insulin resistance. So one of the things that are often considered is that, well, people who gain weight or who are obese or gain weight from antipsychotics, that's the mechanism by which they actually end up with the greater likelihood of diabetes. And what this would show is that, in fact, they start out with that risk even before the medication, and that that risk isn't associated with being overweight or carrying extra fat at the beginning. So this slide again is a slight departure in that what this is again is just another way of showing that there's that decreased risk for obesity at baseline. And so this slide shows what we call genetic correlations. There's a whole bunch of genes that are associated with schizophrenia, with psychosis, with bipolar disorder, with depression, and we can't really identify any specific gene that is this gene links to this disorder. We know that there's a whole bunch of genetic risk, but we can't really quantify it. But we can put it into statistical models, and we can, with a number of other complex genetic phenotypes or genetic expressions. So things like openness to experience. There's no one gene that links to openness to experience, but we can rate people on that, and we can take all of their genetic material, and we can run correlations. And so genetically speaking, we don't actually see a correlation with insulin resistance yet, because we haven't actually collected enough data, although I imagine that we will eventually. But importantly, the point about that patients do not come with a pre-existing risk for obesity is borne out by this genetic data. And so what you can see is, as you move further to the right, so if you look at bipolar disorder, for example, I think we would all agree that there's a large shared genetic risk for bipolar disorder, and that's borne out in this data. And you can see that the genetic correlation is somewhere between 70, 80%. Very high genetic correlation. Going down to the bottom, focusing on what we're talking about today, waist circumference, body mass index, and hip circumference all show a negative correlation, meaning that those who are genetically predisposed to psychosis share, admittedly, a small but non-trivial genetic risk for being low body weight, or in this case, not abnormally low body weight, but being thin. So that there isn't at baseline, there isn't really an expectation that people with schizophrenia should be obese. That genetically speaking, they have at least a slight protection, which goes to show all of the different things that can go into that.
Okay. Hi, Doug, Noordsy stepping in here. So I think that the slides that are here are the last version and not the final one. So sorry, guys, we got a little thrown off because our order is not quite what we expected. But so this slide is referring to microbiome in early psychosis, and so there is now evidence that people who go on to develop psychosis and bipolar disorder have higher rates of antibiotic treatment in the in the year or two just prior to onset of illness. And of course, antibiotic treatment can disrupt the bacteria that live in our gut, and we're now learning more and more about this. So the term microbiome really refers to the populations of bacteria that populate our gut. Jake Ballon was mentioning a moment ago how interconnected the gut and the brain are, and there's now a whole field of this in microbiology looking at the populations of bacteria in our gut and how they influence neurotransmitters, how they influence mood and mental health. So we do now have evidence that not only are people who develop severe mental illness more likely to have had antibiotic treatment, they also have gut bacterial colonies that are significantly different from people in the general population. This has been shown in a variety of other medical disorders that involve the gut, that altered bacteria can contribute to inflammatory processes and such. And so we now have growing evidence that alterations in the gut microbiome can impact psychiatric conditions and risk as well. As we think about lifestyle interventions and helping people managing their metabolic risk, as well as developing a lifestyle that can help them to move towards better health, the microbiome may be playing a role in the background that we're just learning more about.
Excellent. And I'm just also noticing that there are some questions that are coming through on the public chat. Feel free to post questions. I see Tamara was asking a bit about that. Yes, everybody measures the BMI. That's easy because you just step on a scale and measure height, and it's a nice ratio. But not everybody measures waist circumference. And why is that important? And waist circumference in particular is a way of helping to ascertain where a person carrying that fat. And so a person who is, first of all, people can be heavy because they're also very muscular. And that's different than being heavy because they're carrying a lot of obesity and a lot of extra fat. But measuring the waist and hip circumference, and you can take the ratio there, helps to highlight that abdominal obesity in particular. And it's the abdominal obesity, the fat in the stomach, or in the abdomen area, that is associated with greater levels of inflammation and ultimately greater levels of insulin resistance. And so that's why it's important to keep track of changes in abdominal obesity in particular. And it happens that abdominal obesity is the more likely type of obesity associated with antipsychotics. So back on my path towards convincing you that there is a baseline risk for metabolic disease, especially insulin resistance, even prior to medication and in early stages of treatment. This is a meta-analysis looking at a number of different studies of people at early stages and trying to ascertain risks on fasting glucose. And the next slide will also show a little bit of this. Fasting glucose, I mentioned again, is sort of the last thing you would expect to change. And so you can see and first of all, also meta-analysis is when you take a number of different studies and you group them together, and that way you can take a lot of smaller studies, but now you have you end up with what is essentially like having one large study. Meta-analysis have their pros and cons, right? So it's nice to be able to put together all of the data into one, and you can certainly get more power to detect a difference when you have more subjects, but garbage in, garbage out. If the individual studies that are included are not of the highest quality, doesn't matter how many of them you put together, you're not likely to learn more just by accumulating them. So it's sort of always with some trepidation. But in this case, you can see that, so in any study, you'll see that each study has sort of a line with a dot in the middle, and the dot in the middle is the sort of the number that they're reporting. But statistically, there's the range of what could really be expected to have occurred in that study is what's on those sort of tails. And if the tail crosses 0, which would say no greater or lesser risk associated with this, what we're studying, then it's not technically statistically significant. It means that there's at least a greater than 5% chance that, in fact, that the number was associated with chance and wasn't really true. So you can see that almost all of these studies put in there are either cross or very close to approaching that 0 line, which means that the amount that you can, that any of these studies could have made claim that there's impact on glucose is minimal. However, when you do add them up, you see that the diamond on the bottom, the overall, is to the right of the 0 line and does not cross over it, which means that there is a statistically significant increase in fasting glucose. It's moderate, but what's greater, and albeit not as well studied, is the relationship with insulin resistance. And again, this is important because this is the harbinger for development of diabetes. And so here, the studies seem to me to be far less equivocal. The first one is actually on the left, and there's one other that's sort of to the left of the line, but all the others are to the right of the line, and most of them don't cross 0. And you can see it's actually a larger diamond shape. The larger the diamond, the better the signal as well. It's clearly on the above 1 or above 0 side of the line, meaning that there's an increased risk for insulin resistance. So you don't notice insulin resistance. You can't really see insulin resistance the way you can see diabetes, perhaps. There aren't really a lot of symptoms. And so this is why it's important to really test for it, to be thinking about it, to be checking with folks, and to really be thinking about that those metabolic syndrome parameters, because those are all risk factors for developing this. So as we move along the levels of evidence, I started with an old study from one mental institution from the 1950s. We moved to another small study where we looked at people prospectively in a more modern era. Then we moved to meta-analysis, where we collected a number of studies. And now this is what I would call one of the highest levels of evidence, which is a birth cohort, looking at millions and millions of Danish people born over about a 30-year span. And because, of course, about 2.8 million people without schizophrenia, about 9,000 people with schizophrenia. People in these cohorts, because of the centralized healthcare system, they can keep great records on who has what disorders and what diagnosis and medication treatments and comorbid diagnoses. It's all kept in that centralized record. And so what we can see is this is at prior to the onset of starting an antipsychotic medication, because you can look backwards in a big in these cohort studies, because you can find out who developed schizophrenia at some point, and then look to when was it before they got their first antipsychotic, and what were some of the numbers and things associated with it then. And so you can see that the risks for developing diabetes in people with schizophrenia here is tremendous, upwards of 2, 3, 4-fold. In fact, as you get up into into their 30s, the risk for developing diabetes is 6-fold compared to the normal the non-psychiatric population. So a tremendous risk. And then one of the things that they do is you say, okay, well, maybe it's associated with any of a number of other factors. Okay, so it's not that they have schizophrenia, it's that they smoke more, or that they live in a more urban setting, or so here they make a couple of different models where they try to factor out a lot of those things. And even when you factor in age and gender and race, and again, in the Danish cohort, race is not nearly as diverse as we would see in an American population, but all of these different factors that you might think are associated with it, and it still holds up that there's a nearly twofold or threefold risk of diabetes, depending on which model that you're looking at, both of which remain statistically significant. And so, again, these are antipsychotic naive people, so it's not that if this is a relationship to medication, this is before the onset of medicine, that there's still at least a twofold risk of developing diabetes. All right. So I want to shift those. So now we've just talked, and now hopefully I've convinced you that before anybody has tasted their first antipsychotic medicine, they're already, there's something going on that has them already at risk for adverse metabolic state or insulin resistance. And now I'm going to talk about what is related to the medication itself, which is to say that is essentially, I'm talking about pouring gasoline on a fire. But it's hard to really study the specific impact of medication, and that's for a variety of reasons. One is the first exposure to medication is when the greatest risk for metabolic impact is there, which is why it's particularly important in early psychosis population. But also it's fleeting. So by the time a person makes it into a research study, chances are they have already been on an antipsychotic medication for some period of time. They may have already gained some of the weight, and so it's hard to see what was happening in their body at that time very well. And the changes can be very rapid. For those who work in an inpatient setting, you probably have seen people who get put onto medicine like olanzapine, and over the course of a 1 week or 2 week hospitalization might put on 10 or 15 or more pounds. If you wanted to study what was happening in that point, you've already maybe missed the most important changes. Also, of course, this is true throughout studying of psychosis and schizophrenia, that there's a wide heterogeneity of experience. There's a wide heterogeneity. People, one person's psychosis is not the same as others, and it's unclear that there are biological underpinnings that would also differentiate, which also would differentiate the risks of all the rest of the things along with it. Not to mention that antipsychotics themselves are all different, and so there's differences in those effects, and different people. Some people also don't gain any weight on olanzapine, right? Some people gain over 100 pounds, and so there's just a wide range of expectations there. And then, of course, there's a number of comorbidities, lifestyle factors, substance abuse, previous drug exposures that can also make it hard to study. One area where it's a little easier to control for those things is in animal models. So we have tried to study it in rodents in particular, but it's studying other animals. But what I want to leave you with is how remarkably fast the change in insulin resistance can be noted in animals. So especially if you look, we can measure things that, like, when you give an animal olanzapine, you see that they eat more, their metabolism slows down, so that's a pretty bad combination for gaining weight. We can see that there's even impacts on the expression of certain genes. But what is most profound to me is that even within the first hour of the first dose of olanzapine, you can see changes in the liver that connote insulin resistance happening. And I'll go through in a minute a little bit of a proposed mechanism for why that might be happening, albeit it's not a perfect mechanism, but at least it's my proposal for something that contributes to that. Looking at the impact of medication, and specifically in a first episode population, this is from the UFES study, which was a European first episode schizophrenia trial done by Fleischhacker, published a few years back. And you can see that that all of these medications are associated with an increased risk of weight gain. So on the left, you'll see is the percentage of patients who gain more than 7% of their body weight. And remembering, this is people in early psychosis in particular who are so more likely to be touched by this than people who are further along in the course of illness. But look, almost 90% of the people on olanzapine gain 7% of their body weight, right? So if you're a 150-pound person coming into that study, you're putting on pretty quickly about almost 10 pounds or so, a little more than 10 pounds right away. And that, I would argue, that's a pretty profound difference, and especially when we're talking about this being averages. Some are going to be gaining more, some are going to be gaining a lot more. Even though you look down all the way to the right, ziprasidone and haloperidol, which are often considered relatively, weight neutral or certainly less risky. Amisulpride, for what it's worth, is not available in the United States. This is a European study, so they use that. But also, these are the drugs. Olanzapine and quetiapine, I think many of us have an association with weight gain. But ziprasidone is certainly marketed and intended to be less, and probably is among the least risky for gaining weight. And yet, even still, over 30, almost 40% of the young people gained 7% of their body weight when they started it. You can see the average amount of weight that was gained in kilograms. So on olanzapine, it was 15 kilograms, right? Because just because this is on the left shows they gained more than 7%, doesn't say how much more they gained. On the right, you see they gained an average of 14 kilograms, right? So over 30 pounds of weight gain. That's the average. And even on the ziprasidone, they gained about approximately 5 kilograms, or over 10 pounds, right? So these are significant amounts of weight, especially if a person is going to be needing to take these medicines indefinitely and is going to have a hard time losing that weight. So it leads to a bit of a clinical conundrum, though, and we're not getting into relative efficacy of medications, but one of the things that the conundrum we often run into, especially in an inpatient setting, is that olanzapine and clozapine, which are the two greatest risk medications for weight gain and for diabetes, are also probably the best antipsychotics that we have on treating psychosis specifically. And so that leads to a big problem, because if I could know in advance that a person wasn't going to gain weight, I probably would choose that medicine very early. But if I don't know that, it makes it hard to decide to give that medicine to somebody if there's a 90% chance that they're going to gain 7% of their body weight. I'm reticent to give that. So it becomes a big conversation. We'll talk a little bit about how we handle that. But also, now we have this issue, which is that in the general population, it's often considered that obesity comes before impaired glucose metabolism. But here, maybe it's that we don't know actually which is coming first, because there's already these risks before the onset of weight gain. So maybe there's separate mechanisms. We don't know the relative contribution from the peripheral body, the peripheral organs versus like the brain and areas in the brain, and how are they feeding back, and what is going on that's causing this sort of abnormal feedback that leads to this incredible metabolic risk. So I'll go through this slide very carefully. No, this is sort of what we're dealing with. This is not an actual slide. This is, but it's very complex. There's a lot of signaling pathways. We look at neurotransmitters, and we think that those are relevant, but that there may be other either upstream or downstream things that are related to that, and circuits. So it can be a very complex story to start teasing these all apart. I'm going to talk a little bit, though, about dopamine receptors in particular. All antipsychotics do treat the dopamine D2 receptor in some way, shape, or form. It's either an agonist or a dopamine antagonist or inverse agonist, depending on how specific you want to get. But either way, they block the dopamine D2 receptor, or in the case of aripiprazole and cariprazine and brexpiprazole, it's a partial agonist. But either way, the dopamine receptors are involved in every antipsychotic and in varying potency. But we also know, and so it's easy to say as a psychiatrist, well, we know those are in the brain. So that's probably the end of it. Except that it turns out that there's dopamine receptors elsewhere. And just like if you take, you take ibuprofen for shoulder pain, well, it doesn't just know to go to your shoulder because your shoulder hurts. It goes throughout your whole body, but it happens that that's where the inflammation was, so that's why you notice that it feels better in your shoulder. But the ibuprofen is going throughout your body and decreasing inflammation throughout. Well, so too is an antipsychotic going through your whole body, looking for dopamine D2 receptors. And one place where it happens to find them, in no small part, is in the pancreas. Turns out the pancreas in many ways is almost like a mini brain. It contains a lot of the same machinery that is in the brain as far as neurotransmitter expression and things like that. And so it's no surprise that, in fact, these medicines carry a metabolic consequence because, again, the pancreas is the main regulator for insulin and glucose, and therefore also has all these impacts on overall weight. And we can see this in the lab. You can take pancreas cells and put them in a dish, and you can give dopamine, and you can make them release. You can make things. You can release you can give L-dopa to people, and you can make them hyperglycemic. You can put you can put it in a dish. You can dope in a dish, and you can see that it blocks. If you also give blood sugar, it blocks the insulin. And so there's all these different things that show this incredible feedback between the body and the brain. In this case, the brain and the pancreas in particular. To the extent that we don't actually know which is driving this train. Is it what's happening in the brain is sending a message to the pancreas? Is it vice versa? And how is this all being regulated? But for a long time, we did not know that in fact there were dopamine receptors in the pancreas. Now, why does it matter? The pancreas beta cells are the cells that regulate and they release insulin. And so when you block a when you block the dopamine receptor, a variety of things happen. We don't have to go into all of the different downstream parts of this cascade, but when you block a receptor, it sets off a chemical cascade either in the brain or in this case in the pancreas. The downstream result of this cascade of events is that when you block the beta cell dopamine receptor with an antipsychotic, you end up releasing insulin. Well, if you release insulin into the body, and that insulin is just as efficient as it ever was, and you don't have sugar as a result that's there to help balance it out, if you just release that insulin, you would end up with low blood sugar and you'd pass out and die. That does not happen when you take an antipsychotic. So in order for it to release insulin without causing that to happen, it means the insulin has to become less efficient or ultimately more resistant to the blood sugar. As you do that more and more, that's what helps to eventually burn out these beta cells and cause a greater likelihood of diabetes in this model. What we don't know is there's some thought, and you can see that in the sort of the hashed, if you go in the red circle, you see that, so you block the beta cell with the antipsychotic, it leads to insulin release. And what we don't know is does that also then, if you cause there to be an increase in fat and lead to in obesity and also lead to diabetes in sort of two different ways. That part's still being worked out, and what I would suggest is that there are people for whom that is the case. There are people for whom that's not the case, because you see that people on antipsychotics sometimes get insulin resistant or become diabetic even without gaining weight. But this would be the sort of the general model that on the left is as what we usually think of for how people develop diabetes, right? That you eat maybe not necessarily a high-fat diet, but certainly a diet that makes you fat. Lots of carbs and things like that. That leads to obesity, especially in the abdominal area, which leads to insulin resistance, as I mentioned, which then leads to, as the insulin is less efficient, you make more. That's what hyperinsulinemia means. You have a higher rate of insulin. Those beta cells that make insulin are working as hard as they can, but at some point they burn out, and once that happens, now you have type 2 diabetes. What I'm suggesting is a model which is relatively controversial, admittedly, but that in fact, if you replace high-fat diet here with essentially antipsychotics that are, again, because that's causing people to gain weight, but also it's causing directly that release of insulin, and so the antipsychotic is in yellow there, leading to this hyperinsulinemia. That itself can lead to obesity, and so in fact, a hyperinsulinemic state, a state in which you have too much circulating insulin. Insulin is in fact also a growth factor, so it's not surprising that it might be associated with the growth of fat cells as well. But that if this high level of insulin leads in fact to obesity, well, that sets you off into that whole cycle of obesity and diabetes, but also can show how there's a number of different pathways that people can go through. So you can end up with hyperinsulinemia and then go straight to the beta cell burnout and diabetes, or you can go to obesity, or you can go from obesity to diabetes. You can see it gets complex pretty quickly. So my take-home message about the pancreas and is a microcosm for this whole thing that I want to leave you with, is that the pancreas itself expresses dopamine signaling machinery, right? It is just like the brain. There are dopamine D2 receptors and D3 receptors, and antipsychotics are going to get in there, and they will that by blocking them, you inhibit this what would otherwise be the blockade of insulin secretion that is normally there. This double negative essentially means that you're increasing your circulating insulin from medication, and so to people are likely to have already had a higher circulating insulin level, and now we're even more reinforcing that with medication. And incidentally, it's not surprising that these go together, because medication also can work for psychosis, and so that these are all related makes a lot of sense, but it also causes a lot of problems. So with that, I'm going to turn it over to Doug to talk a little bit more about people in early stages of psychosis and some treatment implications.
Well, Jake, thanks a lot. I asked Jake to join us because of his specific expertise in this area, and while he didn't mention it, he's doing some research in this area as well, and looking at potential strategies for helping to manage this cascade that occurs in people with psychosis. So appreciate your bringing that expertise to us this morning. As we're making a transition here to thinking a bit about practical management of people with early psychosis and treatment interventions, we welcome any questions that people may have. Feel free to put them on the chat. And let me just turn this, might help with the microphone. Good. So I don't see any questions coming up. So let's shift into thinking about how we work with people with early psychosis in order to recognize and manage these risks. And you know, for starters, we wanted to go through that lesson in metabolism in order to help everyone to be prepared for the kinds of conversations you want to be able to have with individuals and their families as you're getting to a juncture where they're presenting symptoms. You're considering medication treatment with them as part of their treatment process, and to help them understand the stuff that they've typically heard in lawyer ads on TV or that sort of thing, about medications, and patients often have questions, or their family members, about risk for diabetes, risk for obesity, and so we want to be able to explain that to them well. So the first point here on the current slide is that people in early psychosis are at the highest risk for metabolic side effects of antipsychotics. And Jake referred to that a little bit earlier. There's a number of reasons for that. We also know from clinical trials of people with chronic schizophrenia that people who go into a trial underweight are at greatest risk for weight gain compared to people that start a trial of an antipsychotic medication overweight. So, and as Jake showed you earlier, genetically we know that people with schizophrenia are prone to be somewhat thinner. And if you think about patients that you've treated in early stages of psychosis, they usually present relatively neutral in weight anyways, but if they've had a period of time of poor self-care, maybe their psychosis has interfered with eating or taking care of themselves, maybe they haven't been sleeping well, you often find that people present even with some loss of weight prior to entering treatment. And so as they're considering starting treatment, there may be some initial phase where a bit of weight gain may be welcome. It may be that the person's returning from a state where they haven't been taking care of themselves and are somewhat nutritionally deprived to getting back to a neutral state. So we want to think about, there may be some correction back towards their baseline that may be reasonable, but we need to be tracking for risk of going beyond that. And by definition, for people in early psychosis, they're typically having their first exposure to antipsychotic medications. And as we know, with medication effects that, people tend to have the greatest sensitivity to medications initially, of all types. And then our bodies develop adaptations when we take medications over long periods of time. So the risk for weight gain is greatest. And this has been shown. We didn't put a data slide in here on this, but this has been shown across several meta-analyses of studies of medication treatment in people in early psychosis that average weight gain is greatest in people at first exposure. It's important to also point out that people in early psychosis are also more sensitive to the beneficial effects of medications, to the antipsychotic effects. And so when we think about approaching treatment, and again, I'm probably preaching to the choir here since you all do this every day, we want to think about using medication doses that are quite a bit lower than we typically would for a population of people who've had psychosis for longer periods of time. And we want to start off trying the lowest doses of antipsychotic we can and be patient and careful in our dose titration up so that we give an opportunity for a person to demonstrate a good response to a low dose. This is a lot easier to do in an outpatient setting than it is in an inpatient setting where there may be pressure to get a person stabilized within a few days. So we often see people coming out of the hospital on high doses of combinations of multiple medications, and our work in the outpatient setting is often to scale that back in a way that's responsible for people. But again, almost goes without saying, we want to try and find the lowest effective dose possible for in our partnership with patients to when we use antipsychotic medications to help them minimize risk of side effects. Then the final point here is that the age or stage of life that people are in, is often late teens when they may still be growing. And so people who are in a growth phase appear to be more sensitive to the stimulating effects of medications on weight and weight change. So the American Diabetes Association got together a panel in 2004, and the guidelines that are listed here continue to be considered best practice guidelines for monitoring, and you'll see a lot of studies in the literature these days pointing out how poorly as a profession we do at this, that average rates of following these criteria are around half or less for people treated with antipsychotics. But the recommendations, and actually one of my colleagues at Dartmouth sat on this panel, who's a psychiatrist. It was a blended group of psychiatrists drawn from the American Psychiatric Association as well as diabetologists, and so recommendations are to test at baseline, and that can sometimes be tricky, as we all know clinically. If you're working with somebody who's just approaching care, considering a medication decision with them, saying to them, well, I need you to go off to the lab first before you start your first dose of medication can be tricky. It may represent a barrier if the person doesn't have easy access to a blood draw facility, but ideally we want to get a baseline measure prior to the first dose of medication, or certainly within the first day or two of starting medication, and so we want to be thinking in our decision-making process about how we can get that testing done, and then repeating testing 3 months after initiation of medication, and then annually thereafter if the person's values are normal, and if a person is demonstrating abnormalities already by the 3-month point, then we want to be continuing to test them at least on 3-month intervals if they're starting to show elevations in lipid and glucose. And I think on the next slide here we have what you should be testing. And again, this should be familiar to everyone, but basically measures of lipids and glucose. And so lipids includes the cholesterol measures that Jake presented to us earlier, so total cholesterol as well as the subcomponents, where HDL is the healthy or good cholesterol and LDL being the unhealthy or bad cholesterol. So you want to see HDL above the threshold and LDL below, total cholesterol below. And then two ways to measure glucose. The most sort of the gold standard is the fasting glucose. So what is the person's blood sugar when they haven't had anything to eat for 8 hours? The hemoglobin A1C is a measure of long-term, sort of an average blood glucose. And if you're testing somebody and it's just going to be impossible to get a moment where they haven't eaten for a long period of time, the hemoglobin A1C can represent a good proxy where you don't have to worry about the effect of recent consumption. And ideally, if a person does present fasting, you can get both. Now, I've been surprised. I had a patient who came in to see me mid-afternoon the other day we wanted to get lab work done, and it didn't occur to me until I asked him. Well, he actually hadn't had anything to eat that day because he'd only gotten up a few hours earlier. So, it is worth checking with patients and not making an assumption that 2 in the afternoon means they've already had a meal. And so you may find your opportunity for fasting, measure is there. But the hemoglobin A1C can still be helpful. I mean, normally if you get a normal fasting glucose, you'll find your hemoglobin A1C is also normal. So if you have to be parsimonious with cost, excuse me, the fasting glucose itself is fine if the person is fasting, and if not, the hemoglobin A1C can substitute. And then the other part of the guideline is that at every visit we should be measuring vital signs, including blood pressure and weight, and remembering that blood pressure is part of the metabolic syndrome, and weight, obviously, the easiest measure to track of a person's metabolic status. And as Jake referred to a bit earlier, weight is tricky in its own way. As we work with people to use exercise as part of their health management, we often find that people's weight may go up a little bit before it goes down, and it turns out that muscle tissue weighs quite a bit more than fat tissue does. So as people build muscle mass, they may actually find that their weight doesn't drop or even rises a bit as they're getting more fit. So weight is a gross measure. It's impacted by how much fluid a person has had to drink, when they've last had a bowel movement, that sort of thing. Labs, the most accurate weight is first in the morning, before a person starts to consume things and after they've relieved themselves. And so if a person is motivated for tracking weight independently, you may ask them to track that at home. But certainly checking weights at each, clinical visit is an important tracking tool. We actually, in our electronic medical record, can set it up so that in each progress note, it will show the last 3 weights in addition to the one for the current visit, so that we can efficiently track with patients their weight trends over time. And then the last point here is to really check in with our clients around their establishment of primary care, and for folks who don't have a primary care in place, to help them to initiate that and maintain a relationship with a primary care doctor, if for no other reason for annual health screening, but should metabolic issues come up, it's great to have a partner with us. Psychiatrists vary in their comfort in managing these things. I know some psychiatrists who will prescribe statins and glucose-lowering medications routinely, and blood pressure-lowering medications routinely, but many of us with less general, medical training, will want to partner with a primary care doctor to get, adequate care for people. And of course, it depends on your setting and resources available. So as we think about metabolic risk, we ideally want to be getting ahead of the game and thinking about this as part of our informed consent discussion with patients, not only prior to starting medication, but on an ongoing basis as they respond to and manage medication over time. We may also be thinking about this after some significant changes have occurred, such as weight gain or change in lipid or glucose measures. We have a number of options available, lifestyle and behavioral management, including both diet and exercise interventions, thinking carefully about medication, both choice of psychiatric medication as well as medication specifically designed for regulating metabolic disturbance, and then integrated healthcare, as we alluded to a moment ago, making sure that we have a good partnership and good communication with a primary care practitioner as part of the individual's care, ideally in the same setting, working shoulder to shoulder, but if not, trying to achieve that virtually through communication in order to ensure that the person's health care is well integrated. And we'll get into each of these components a little bit more. So on the diet end, there's a variety of things that we think about. Jake was alluding to a moment ago, the processed foods that people may eat, the risk diets. The older slide that he was showing referred to high-fat diets. Is now more concerned about high-carbohydrate diets. This literature is much more developed in other psychiatric disorders, particularly depression, more so than it is in psychosis. But I actually did a project this summer with a medical student who was working with me to review this literature and to try and understand how specifically it might apply to people with psychosis. And there's a very nice study that was done in Australia recently with people who had demonstrated treatment resistance in depression, which found that eating a modified Mediterranean diet actually improved their depression scores relative to what they, with no change in their medications and psychotherapy. And people in the study, varied from having no other treatments to, having ongoing psychotherapy or med management. So diet does have an impact, at least on mood, and there are some, more, smaller studies suggesting similar effects in people with psychosis. We also have seen in the depression literature that eating a lot of processed foods is associated with poorer outcomes relative to more whole foods. So we also know specific components such as fish oils have been shown to be associated with better outcomes and less symptoms, both in mood disorders and in psychotic disorders. Leafy greens and citrus are on this list because of the evidence that B vitamins, and particularly folate, are involved in neurotransmitter synthesis, and that deficiencies in folate and folate metabolism are found in people with psychotic disorders as well as mood disorders. So the leafy greens and citrus are the natural whole foods that are represent the B vitamins that are an easy source that people can gain those. There's also some recent literature on vitamin D and associations between low levels of vitamin D and more cognitive impairment in people with psychosis, although there aren't clear studies yet suggesting whether vitamin D supplementation will reverse that, but certainly harmless enough intervention for people to try. And again, I would recommend before jumping into supplements and all of that to start off with a good assessment with an individual and their family about a person's dietary intake. I usually recommend trying to eat a healthy diet with and point out that the literature repeatedly finds that getting nutrients from a natural food source rather than from a supplement is more efficacious than supplementation. But certain situations like fish oil in particular, it's hard to eat enough fish to get the level of fish oil recommended for helping with best mental health. So fish oil supplement is something we're often using, again, with that together with the evidence from the Austrian studies showing benefits in early psychosis. And then there's this concept of MACs, or microbiota accessible carbos. And so this comes from the microbiome literature again, that the gut bacteria, the healthy gut bacteria, require these carbohydrates that are basically represented in fibers. So carbohydrates that we can't digest, which will stay in the gut and will support a healthy microbiome. So again, the simple way to describe this is that eating a high fiber diet is the best way that we know of to support a healthy microbiome. We're also planning a study that hasn't gotten funded yet to collaborate with our colleagues in microbiology here to actually look at a dietary intervention in people with early psychosis who may have altered microbiome, and see if we can help to correct to a more normal microbiome and measure effects on the psychotic disorder. Then thinking about medications, we want to be thinking about antipsychotic medications and their relative risks for weight gain and insulin resistance. And again, it's I'm sure I'm preaching to the choir here. You would have to be under a rock to not have thought about this in the last decade or two with so much attention to it. But we do know that, as Jake identified earlier, that antipsychotic medications vary in their propensity for weight gain. You should make the assumption that at early stages of illness, any antipsychotic medication carries risk for for weight gain. We'll go over the relative risks. As Jake pointed out, there's some, there's certainly data to suggest that that's related to the core mechanism of dopamine, altering dopamine 2 function, although we know that the relative risks of various medications doesn't correlate one-to-one with their dopamine blockade, so there's other factors involved and a whole variety of mechanisms from histamine, antihistamine activity, and certain serotonin receptor activity have also been implicated in impacts on appetite and satiety and such. But one of the things I always carefully educate people about in this stage is appetite and satiety. So important discussion to have, and that's central to the changes in consumption that we often see when people are taking antipsychotic medications. So as I have a conversation preparing to use a medication, and then as I'm tracking with people over the course of their initiation of a medication, I prepare them for the possibility that there may be distortion in their appetite and in their ability to experience fullness. That's what we call satiety, the ability to feel full after you've eaten an adequate amount. And I'll usually draw a parallel to a phantom limb syndrome. So I'll talk about how, if a person has loses an arm, they may still feel pain in their hand, even though the hand isn't there. And then in a similar way, we can have a sort of a phantom hunger or a failure of satiety to occur, so that we may get a signal, gosh, I really need to eat, I'm really hungry, even when my body doesn't need caloric intake at that moment. And Jake described to us why that may be occurring, right? If insulin's being secreted inappropriately, and so I'm getting a signal about my body needing calories when it may not. So I try to prepare people for that possibility, get them to think about their ability to manage a hunger signal. Are they somebody who really struggles when they feel hungry, or is it something that's been easy for them to ignore before? What would it be like for them? And then track that, because I find that people who are experiencing a tremendous amount of appetite effect from a medication tend to be at the greatest risk for having weight gain naturally, because they're getting signals to eat at times when their body may not need calories. And it's sort of a classic description would be the person who wakes up in the middle of the night and is so hungry they need to go to the kitchen and make themselves another meal before they can go back to sleep. And of course, we often have people take their medications at bedtime, so it's, take the medication, they feel sedated, they fall asleep, and 3 or 4 hours later they're waking up with tremendous appetite stimulation. So again, that's a real marker for somebody at risk for weight gain, where we may want to consider how well they can manage that behaviorally, certainly prepare them well for it. I've had many patients who experience this who are able to sort of make the shift from, regulating their consumption of food based on their experience of hunger and satiety into regulating their food consumption in a planful way by, making a plan for, these are my nutritional needs. If I eat this amount, I know I'm okay. I can ignore my experience of hunger. Again, some people feel comfortable doing that, others don't. And so the next bullet here is metabolic medications, and we do know that we have a variety of medications that may be able to suppress appetite, and that includes some of the diabetes medications like metformin, which is probably the best studied, but still, pretty limited evidence. But metformin is an old diabetes medication. It can also be used for pre-diabetic conditions. It helps to improve insulin responsiveness, which again fits into the mechanisms Jake was talking about earlier, and also is associated with some nausea as a side effect and can lower appetite in relationship to that. There are also medications like topiramate or Topamax, which has a direct effect on suppressing appetite, and again, some weak evidence that can be helpful in people treated with antipsychotic medications. And then, medications that directly manage glucose and lipid elevation when they occur. And again, you may feel comfortable prescribing things like metformin, things like statins yourself, or you may want to collaborate with a primary care physician in order to manage those.
And then just there was a very small study that just was published recently, looking at a medicine called exenatide, also known as Byetta, which is another type of diabetes medication that's been shown actually in treating people with diabetes to also, unlike most diabetes medications that are associated actually with modest weight gain, it's associated with some weight loss, and in a small study was shown to help reduce weight by about 4 kilograms in people who are taking clozapine. So that one is still too early to generalize, but certainly will be interesting to follow that story and see if, in fact, these GLP-1 agonists, as they're called, or but exenatide being the one that was studied, actually, if that shows some promise also as being something else to add.
Yeah, and I appreciate you bringing that in, Jake. It's nice to see that, beyond just the findings with metformin, which, started 20 years ago, that that we're starting to branch out and look at other medications in this area of metabolic regulation and their potential benefits for people. The study that Jake referred to was not an early psychosis population, but some of the studies, the most specific studies around early psychosis, have actually involved metformin, including the initial studies with teenagers in the McLean group. So we'll need some more specific studies, and it does make sense to look at. Now there's a variety of non-insulin diabetes medications that have been developed in the endocrinology field that we're only beginning to start to look at and their potential roles here. So this is my messy slides where I sort of pulled together the data on side effects of the variety of medications, and you'll have to, I think my abbreviations across the top for different types of medications are relatively easy, relatively transparent. So CPZ would refer to chlorpromazine or thorazine, HAL being haloperidol or Haldol, then clozapine, risperidone/paliperidone, olanzapine, quetiapine, and ziprasidone. So those are the medications listed here, which at the time I wrote this slide were the predominant medications. And then you see the relative risk for a variety of side effects, with more pluses representing higher risk, naturally. And you can see in the fourth row, weight gain risk listed, and as Jake referred to earlier, clozapine and olanzapine being similar and at the highest level of risk for medications, for antipsychotic medications, and then chlorpromazine and risperidone, not far behind, quetiapine there as well, haloperidol a bit lower but still has risk, and you can see ziprasidone sort of more moderate. And this is actually, this slide was not specific to early psychosis, and as Jake suggested, all of these probably need another plus on them for the early psychosis population. And then in the next slide was a slide to catch up some of the newer medications, and just to keep you on your toes, this one's oriented the other direction. I apologize for that. But now you see weight gain and glucose in the columns on the right, and so ARI being aripiprazole and ANP being acenapine, iloperidone, and then lorazepam. And again, as you see, there's most of these medications in the mid-range. Aripiprazole now has brexpiprazole as a partner to it, and both of those are in the sort of 1 to 2+ range. And lorazepam, across a number of studies, has consistently seems to be the antipsychotic with the least amount of weight gain associated with it, and again, ziprasidone next of the currently available medications. With the older agent molindone, which is no longer available, actually showing some average slight weight loss associated with it. And then we're going to go into a little section on exercise. And so we often find that when people are developing psychosis, their lives have been disrupted and their routines have been disrupted, and they're often not exercising. And so as treatment providers, part of our role is to help people make behavioral change to help them move towards exercise, both for metabolic reasons and for cognitive reasons. This is an old electron micrographic slide showing the loss of dendritic connections in the individuals with schizophrenia in the panel B and C relative to a person without schizophrenia. And we now know that exercise is the most powerful method to stimulate synaptic connectivity between neurons. And we find that people who exercise show increases in gray matter volume, particularly in areas of the hippocampus, which is associated with memory and cognitive function. So we've been working in a number of studies, both here and with colleagues, on using exercise to help people to manage their early psychosis. We actually have a paper coming out shortly on an individual who was able to get into remission from early psychosis related to a very vigorous physical exercise regime, and are beginning studies to further explore the cognitive effects. This is actually a nice meta-analysis by Joe Firth, who's a postdoc at University of Manchester, looking at the literature in 10 controlled trials showing strong effects of physical exercise on cognition in people with schizophrenia. That's from Schizophrenia Bulletin. And we know that physical exercise stimulates the release of not only endorphins, but also norepinephrine, serotonin, and dopamine, the neurotransmitters that we think about in our psychiatric management. It's also a very potent stimulus for release of brain-derived neurotrophic factor, or BDNF, which is primarily responsible for stimulating that synaptic connectivity we were just talking about. The other interesting thing here in the third bullet is we've known for a long time that after people exercise, they store more glucose in their skeletal muscle to prepare for the next episode of exercise. Repeated exercise also stimulates the development of greater numbers of mitochondria in muscle cells, and mitochondria are the energy burning sort of the furnaces, if you will, of our skeletal muscle, so that regular exercise prepares the body for being efficient at burning glucose. And again, there's a whole other lecture would be the use of physical exercise for the treatment of diabetes. And it turns out that actually, people with either pre-diabetes or type 2 diabetes can often get into remission through physical exercise, which can help to normalize the whole metabolic regulation system that Jake was going over with us earlier. Well, same things are happening in the brain. We find that glycogen storage in astrocytes, which are supporting cells for neurons, increases after exercise, particularly, and we see enlargement in frontal cortex and hippocampus. And then also tighter glucose regulation, so that those periods of hyperglycemia that Jake was showing us earlier actually have toxic effects on certain areas of the brain, particularly an area called the insula, which is involved in memory. And that's thought to explain why, as we age and our ability to control glucose gets a little less tight, that we tend to have cognitive decline in aging, and people with better glucose regulation often do better cognitively over time. And so as we've been describing, physical exercise improves the metabolic machinery. We manage glucose more efficiently, and that can help with cognitive function. So we use both the physical, metabolic, and cognitive potential for physical exercise to help motivate our patients to get involved with regular physical exercise, recommend it for every patient, and then use this strategy that we described here for helping people to make successful change. So think about their current capacity, think about what they've enjoyed doing before, set a target for 30 to 60 minutes of exercise 3 to 7 days a week. But if the person is currently doing nothing, it may be that a 10-minute walk twice a week is a starting point, and then we help them to get a success with that and build it up and gradually move towards goals that approach this. We do know that more exercise is better to a point, and most studies show that about 3 hours of exercise a week or this formula of 150 plus 2, which is 150 minutes, 2.5 hours of aerobic exercise plus 2 strength training sessions of a half hour or so per week, has been shown to have the greatest impact on mental health as well as physical health. Having an intensity, at least at the moderate to vigorous level of exercise, with, again, more vigorous, having more effect both for physical health and for mental health. And as I alluded to earlier, really thinking with the client about what they would enjoy doing, because the goal here is not just to induce exercise for a brief period of time, but actually to help a person make lifestyle change that they can stay with over time. So what do they have access to? What can they afford? What are they familiar with? And what do they enjoy? It may be that a person who played team sports as a kid, let's say they were a soccer player, which involves a lot of running, and they enjoyed that, so they may be more interested in taking up running or joining an adult soccer league, whereas another person might have been involved with weightlifting or swimming or some other activity in their life, and that can be a nice place to start a conversation with people. You also want to think about people's preferences for variation versus repetition, and some people will get bored and want to do a variety of activities, whereas others will want a set routine. And then at each follow-up visit, consider adherence to the plan the patient created, what impact it's had on their core symptoms of their psychotic illness, how it's affected their sleep, appetite, energy, and well-being, help them to refine their plan and build their success. And a lot of times that may be getting to the point where people start to sign up for competitions or events that give them a motivation for their training. And thinking about triggers to lapsing in their exercise and goals over time. And so for take-homes, metabolic risks are greatest at the onset of treatment, and exercise is a potent and important treatment both for physical and for mental health. And we want to be thinking about diet and exercise at every visit with our patients. I think that's getting us near the end here. So again, we've gone over the links between psychosis and metabolic diseases, the importance to monitor from the very beginning of treatment, when we recognize that there are metabolic problems, to intervene early and to track carefully, and to think about diet, lifestyle, exercise in addition to medical management as part of integrated care for people and helping them with wellness. I think we should stop there because we want to leave time for any further questions. We did pull together a few other resources on our final slide set, so maybe we can post that so people can access it on the website.
But I know that Tamara has posted the link for joining PepNet, so I would encourage those who haven't joined to click on the link and please consider joining. It helps. There's an active listserv with a variety of other webinars that you might be interested in, as well as a nice way to learn about what is happening around the country when it comes to early psychosis. It's a network that is growing rapidly, so I encourage you to sign up and check that out, please. And I see that some of the other websites that we had suggested are making their way on here now too. So Tamara's posted about a group that's going to be meeting at the Early Psychosis Association meeting coming up in October. And then we thought it would be interesting for folks who may be interested, who want to hear more about what's going on in psychosis generally. There's a new website called psychosissummit.com that's been started by a group near here that is posting long-form interviews with people who treat psychosis in a variety of modalities. So Doug and I and Dr. Kate Hardy have all participated and will be up on the website shortly, but then there's a variety of other folks that may be interested. And then On Track New York, which I would say is the gold standard for early psychosis, has a real wealth of information on their website, but in particular, there's the sort of medical manual that goes into some of what to think about in early psychosis and has nicely written out a lot of what we were talking about today as far as how to monitor and manage that. So those are some resources that you may want check out. And with that, we have a few minutes for questions, so we'll look on the public chat, I guess, for any other questions that may come up.
And we probably can unmute people as well if anybody wants to ask their question out loud.
I went ahead and unmuted all of the participants, so if anyone wants to ask a question verbally, feel free to. You are all unmuted.
Well, appreciate everybody signing on today, and without hearing any other questions, Tamara just put up there, we'd be happy to have people email us with questions that may come up afterwards.
Yeah, actually, there are two questions posted. They were just typing. So.
Yeah, no worries. I see them there. What about ketogenic diet and psychosis?
Yeah. I don't know that I can jump in there a little bit. I mean, ketogenic diets have gained popularity. It's essentially a very low carbohydrate diet, and have at least shown some effects on helping with weight loss in people in the general population. I don't know of any study of ketogenic diets specifically in people with psychosis, and of course, if a person has diabetes, a ketogenic diet could be risky. Of course, developing excessive ketones is a dangerous state in diabetes. Jake, anything else that you would add?
Yeah, I mean, I'm not familiar with specific studies, although I will say that anecdotally I have a couple of folks who have told me that they really like being on a ketogenic diet, but I don't know of a specific literature. Sounds like maybe you've seen a recent study that maybe I haven't seen yet that's come out, but yeah, I agree that, if a person does have diabetes, diabetic ketoacidosis is a state that can be very dangerous if they have too many circulating ketones, because diabetes in and of itself is a state that is associated with elevated ketones at baseline.
Yeah, I might just add that, being here in California, we certainly have a lot of people who are thinking about diet trends, and so it's not at all uncommon for our patients to come in with interest in following one diet or another, and we usually encourage people to give it a try, assuming that they're otherwise healthy. And as Jake mentioned, we often find that one diet or another may click for somebody, and they may feel benefits for energy, for weight management, for appetite management. And so, I would say the literature in general is not settling on one diet plan being better than another for managing metabolic risks and such, and that what's most important is something a person can make a sustained lifestyle change around. So if something, I would encourage clients to try things out, because it will, if nothing else, increase their focus on what they're eating and trying to eat healthy, and help them to find what can work well for them in managing their dietary consumption.
And so thanks, Andres, for the question, and also for sending out that article. I look forward to taking a look at that after we're off the webinar here.
Appreciate that.
And then, so it looks like Brooks is asking about appetite suppressant. So appetite suppressants are generally risky, and most appetite suppressants are, the most common ones are stimulants, which come with a risk at baseline of increased risk for psychosis. So those, so stimulant medications are generally low to start, especially if somebody in the early stages of psychosis. So aside from those, there are a number of other different appetite or satiety-related medications that have been looked at. I'm not one who typically is using those, and nothing has really borne out in the literature, either because of risks, psychiatric risks, or because of just general being ineffective.
I would just add there then, some of the medications that may have some appetite suppressant effect that we're more familiar with would be medications like bupropion or Wellbutrin, topiramate or Topamax, and so if there's I wouldn't use them only for appetite suppressant reasons, but if I'm thinking with a patient about, managing mood symptoms and an antidepressant seems appropriate, we might choose bupropion over another antidepressant option in order to gain, the appetite suppressant effect from it, which is modest. Again, topiramate, I have sometimes used it primarily for appetite suppressant effect. If so, I'm going to keep the dose pretty low because there's a risk of cognitive impairment with moderate to higher doses. But certainly if there was a reason to be using an anti-epileptic medication and there's at least, maybe some, mood stabilizing effects of topiramate as well, then again, we might consider it for its, for dual benefits there.
And those are Brooke, you're still typing a little bit there, so we'll wait to see your follow-up. Yeah, right. So metformin is I wouldn't think of it as classically an appetite suppressant specifically, although it does have some mild appetite suppression effects. But that is definitely, I would say, the best studied medicine for use for antipsychotic-induced weight gain thus far. Although the evidence is modest, and generally what we see with metformin use is that you can see some improvements in triglycerides, which again are an important risk factor for developing diabetes. But also you can see kind of the cessation of weight gain more likely than you see a reversal of weight gain, which isn't to say that that's not important. It's nice if you can arrest somebody's weight gain, and therefore obviously the idea is that maybe you would then start using metformin on the earlier side, which is, again, sort of still a relatively open question whether it should be automatically given at baseline. But nonetheless, that would be the first treatment of choice when you start to see that somebody is starting to rise up there. But I also wouldn't want to oversell metformin as this thing that you can add and therefore feel very protected from the metabolic effects. But at least it provides maybe some protection, and for some people better than others.
And just to echo that quickly, if you actually look at the studies that have shown benefit of metformin, it's primarily when people are randomized to take metformin or not from the very point that they start taking medication. So that, having had a fair amount of experience trying to use it after a person has already accumulated weight gain, as Jake said, it doesn't seem to have a lot of weight loss benefit, maybe minor. So the greatest benefits may be up front. How do you know when you should use it? I would think about, I'm more likely to use it when an individual patient tells me that they're very concerned about weight gain risk. They're maybe they've had a history of gaining weight with other medicines like antidepressants that they've taken in the past. Maybe there's family history of diabetes. It becomes part of the shared decision-making process. So I certainly don't personally routinely recommend it to everyone, but where weight gain and metabolic risk concerns are more important to the individual and their family, then we may want to consider using it either from the start or from the very first point that we're noticing that first pound or two of weight gain, that person may want to get right on it because the preventive effects may be greater than the ability to reverse weight gain down the line.
So being mindful of the time, we're getting the high side from Tamara. I would be happy to entertain other questions either offline or in maybe we could do a subsequent kind of office hours type thing at some